delighted that we have three physician leaders with us. As you all know, sometimes that in our history of healthcare, physician leadership has been an oxymoron. It is not that way anymore. And so first, Dr. Howard Grayman, the CEO of Peace Health Medical Group, Dr. Richard Popeil, the CMO and EVP of Cambia Health Solutions, and Dr. Ralph Prowse. I'm trying to remember that. Ralph Prowse, the CEO of Oregon's Health Co-op. Thank you, gentlemen, for being here. And so let me just start. Howard, I know you've thought a lot about this, and we'll get to the news that Peace Health made around this soon, maybe now. But what do you see? How is the definition of value changing from where you sit, leading a medical group closely aligned with a multi-state hospital system?
Well, from the physician group, I think there are two big buckets in which I would think of this. From the physician group, and first of all, I would always define value as the old-fashioned equation of quality patient experience divided by cost, and we look at it that way whenever we make any plans. But from the physician point of view, I think what we need to do is focus on executing in the area of population management in a way that, frankly, most health systems and doctor groups haven't done, with the exception perhaps of Kaiser over the years. And that's all of the basic functionality that's part of the medical home is the common term used, but whatever you call it, it's providing better access, taking care of hospitalizations and transitions more effectively, creating registries where the most complex patients are identified and case managed so that they minimize the use of the expensive portions of care and also get their health better so they stay out of the hospital. Changing physician behavior so that we begin to practice more responsibly, evidence-based way, so that we are prescribing generic medications, we're not overusing labs and x-rays. I'm one of those people that believes it's probably true that up to 30% of what we spend for healthcare really doesn't provide any benefit to our patients, sadly. Over the years, we've gotten used to that, and we need to learn how to do it better. So I think, in general, redeveloping the behavioral patterns of physicians, which we all know is an easy task, is probably the biggest thing that a medical group is facing in the new world of pay-for-value. Now, as part of an integrated delivery system, our medical group has a particular, a different and additional responsibility, and that is we all know that if we all do our job well, the need for inpatient beds is going to shrink, and our medical group, although it's 800 doctors in 3 states, only is 10% of our revenue for our entire organization. So we need to learn how to expand our network of care and the influence of our hospital so we can continue to have those high-cost parts of our system properly utilized by having a larger catchment of patients. So the medical group's job is also to grow, not necessarily by employing more doctors, but by aligning with physicians in the communities that we serve, so we have a greater footprint, if you will.
And tell us just briefly about the vision, or what is going on, what was announced this week in Southwest Washington by Peace Health and the Vancouver Clinic joining.
Well, this is a great example of thinking, rather than being wasteful and building a medical group to compete with an existing strong group, one of the communities where we have our presence, we've decided to become partners with a physician-owned multi-specialty group called the Vancouver Clinic, which is over 200 physicians. They're the largest organized medical group. They're larger than our Peace Health group is in that town, probably twice the size. And we've decided to come together and develop an independent practice association and begin looking to work with payers to take risk contracts and begin to together reduce the cost of care and maintain the quality of care. This is a fairly new experiment that we've just launched, and we're trying to figure out how to do it.
Yeah, looks good from where you sit today, right? We'll see how it looks 5 years down the road. Richard, how about from where you sit? Physician leader at a major health plan. How is the definition of value shifting as you view the scene?
So just to capture the point that you made a moment ago, we spend $2.7 trillion. Probably when they do the calculation, it's going to be closer to 2.8 after the last year. $2.8 trillion on healthcare in this country. It's about 18% of GDP. The closest industrialized country to us is, I think, the Netherlands. They're at about 11 to 12%. And your point was that about a third of that, or $900 billion, is related to healthcare waste, inefficiency, fraud and abuse, and lack of coordination of care. And I want to make this point because I think the three of us, and I'm just getting to know both of these individuals as well as others. I just moved here to the Northwest recently. I'm sure if we spent some time together, they have in their respective current and prior roles have been working hard at trying to get at this issue of cost and also the inconsistent quality that's delivered to people in this country. And people have been working on this for 25 years. So when you talk about value and you look at the outcome of what our healthcare delivery system has been able to produce today, there's a big disconnect. So what's happening today, in part because of that, in part because of healthcare reform, is a rapid transformation around this value equation. So what had been partners before are now competitors, so delivery systems are becoming delivery systems and health plans are becoming delivery systems, and new entrants that are disrupting all of that, like Walgreens and Walmart, are coming into the equation. So we're in a bit of a dust-up right now relative to healthcare, but all of these are what I would consider experiments, directionally on the right track, and it's kind of wait and see in terms of the value that they deliver. And so, like many other organizations, our organization since January has launched about 31 accountable care, we call them accountable health, to embrace and encompass wellness and prevention arrangements across the 4 states that we do business in. And that is around, again, to your point, population health, changing the visibility of a physician from the next patient who goes into the office to the entire population of patients who they care for, whether they're in the office or in any other environment. So having that broader, comprehensive view and creating navigation and coordination across the continuum. So that's still unproven in terms of how effective, how much value it delivers, but there's certainly some very promising early results that are coming out in many markets around the country.
Yeah. So Ralph, I would assume that as you have developed Oregon's Health Co-op and as you've thought through the exchange, or rather just entering the Oregon market generally, that this question of a different value proposition from other traditional health plans has probably been central in your planning and thinking. Shed a little light on how the co-op model of a health plan is addressing this question of value.
Well, under the Affordable Care Act, the creation of co-ops, or consumer-operated and oriented plans, was intended to be inserted into the healthcare markets specifically to be something of a disruptor, actually. In many of the markets across the country, there were only 1 or 2 or 3 large health plans, maybe there anyway. There were no guarantees that those plans would even play on the exchange or play with the Affordable Care Act. So there's that piece, bringing competition into the markets. And then, of course, the other overriding issue there was the bringing the consumer voice, the public option, if you will, into healthcare and creating some sort of an entity that could be the expression of what the consumer actually wants in the markets. This was kind of a hybrid arrangement that was agreed to, a compromise, if you will, between the political faction in the country that is pro-single-payer public option and those that weren't. And the creation of co-ops was really the blend of the two. So in my organization and each of the other 24 co-ops in the country, we will have boards of directors comprised in the majority from the members that organization serves and provides healthcare benefits to. So everything that the organization does must be centered on what those consumers actually want in the market, which I've learned over the last year is actually quite different than what I thought it was in my prior role and roles in Oregon.
How so? How so?
Well, how so? I traveled around the state last year, met with over 2,000 Oregonians, collected even more feedback from survey work that we did, because I thought it was the appropriate role for a co-op to start out with. Go out, listen to people, see what it is that they do want. And we asked questions in these focus groups, you know, what's important to you? How important is your health? How big a deal is your budget right now for you? And what's working or not working in terms of your insurance plan and your insurance coverage? And I learned some strikingly different things than what I'd learned to believe before. For example, I had kind of grown, I think, a bit cynical from the health plan perspective, thinking that people really aren't that engaged or activated around their own health, and they were quite content really to sit on the couch with a remote control and a bag of Cheetos, you know, and watch TV. I could not have been more wrong. In every single focus group I sat in on, people told me about how they were struggling to stay healthy, move more, lose weight, quit smoking, et cetera, et cetera. It was a big deal, high priority. And I learned that they wanted health care in a very different way. They wanted it in their most convenient possible terms. They wanted to be prudent purchasers, and they couldn't figure out how to do that because of the complexity of the whole payment model that we've all faced. And by that, they would say things like, we never know what we're going to actually have to pay for something because we get co-payments, but then there's the co-insurance element that comes in and the 20% out of a pocket there, and that's kind of a gotcha. And then there's the deductibles, and that's another gotcha. And then if I go to the hospital for an outpatient surgery procedure and I get a bill from the anesthesiologist, even though I thought I went to the hospital, it was on my network, and I thought the surgeon was in my network. Turns out the anesthesiologist wasn't contracted, so I'm ending up paying the difference between what the health plan allowed and what the billed charges actually were. So it was all this about these gotchas, and it comes down to this. People want to be prudent purchasers. They are cost conscious. They're living on slim budgets. The economy's tough, but they can't do it under the current scenarios that health plans provide to them. So my job as a co-op was to listen, and it is to listen, and that's what this organization must always do and always be very patient-centered in that. And what we translated this to were some very unique Oregonian kinds of things, like bringing on naturopaths as primary care physicians, because we heard that in every single session, and that's weird, and it's uniquely Oregon. And when I go anywhere else, they look at me and shake their heads and think that that's just bizarre. Frankly, I would never talk about that in a room full of actuaries unless I first charged up the AED and handed out Depends to everybody in the room, because we'd have a mess on our hands in a minute, because you can't predict these costs. And the convenience factor, you know, got down to we want to be able to call our doctor and email our doctor and save ourselves the time off work and save the dollars associated with an unnecessary office visit. I don't know how many here have had to go to the doctor before just to get a prescription refill when there was really nothing really wrong with you. But that sort of thing really could just be eliminated from the system.
Yeah.
And then we got rid of co-insurance just because it's a nightmare for everybody to administer. From the physician side, it's a nightmare to go about that collection cycle. And from the consumer side, it was terrible. So the co-ops, I think, bring into this whole discussion that very, very consumer-focused, consumer-controlled, consumer-oriented kind of value statement. It's all about the consumer in my market, and bringing them together with providers, I think, to work out these nitty-gritty details of how to make it better.
Yeah. So Richard, you know, I commented earlier today, and I find this true with me and our firm all the time. We just are so busy, we forget that it's about patients. And so, you know, in Ralph's comments, the consumer is central to their model. I know it is central to how Cambia and Regence approach the market, but flesh that out for us. Tell us a little more about how Cambia and Regence is thinking about the consumer, how they're putting the consumer in the center, and maybe differentiate between Regence and all of the thinking that goes into the exchange work, and then all of these other very, very consumer-centric organizations underneath the Cambia umbrella as well.
So there were a lot of questions in that one question, so let me see if I
tend to
can...
ask 5 or so, and I'll
let me
take
see
your
if I
pick
can
about
parse
where you
them
go
out.
with it. Yeah.
So I mentioned earlier that I just came here. I've lived on the East Coast all my life, and I moved here in early January. And one of the main reasons I came was for the opportunity at Cambia Health Solutions. Regence is a set of health plans that sit underneath the parent company, Cambia Health Solution, And that's what Health Solutions, and that's what we are, a health solutions company. So in addition to providing health plans, which is health insurance, which, as I think everyone in this room knows, insurance, whether it's health, auto, or life insurance, has saved millions of Americans over the last 100 years from financial catastrophe because it spreads risk across a population. But one of the things that really got me excited about Regence in particular is they have really been a front runner in terms of really focusing on the consumer. That has been historically their sweet spot, and they've built a whole set of capabilities designed to engage and support the consumer experience.
So how so?
I'm sorry?
Speak to that. How so? What are some examples?
MyRegence.com, which was created in the early 2000s, which was a consumer portal, a wellness and prevention capability that encompassed things like health risk assessment and biometric testing, as well as categorization of individuals at risk and reaching out with navigators and coaches. Those kinds of things were developed at Regence years before they were developed at a lot of other health plans, including the health plan that I came from. In the last couple of years, Regence has expanded its focus, in part because of Cambia Health Solutions and some of the assets that it has developed, the transparency tools in its subsidiary company called HealthSpark. We have a company called CoPatient that helps consumers navigate through the financial struggles that Ralph was just alluding to a moment ago. So there's lots of examples where both Cambia Health Solutions and the Regence family of health plans have really delivered on the consumer experience. That said, we're moving into this new world in the context of healthcare reform, where the market is shifting from basically a group market to a retail market. And so when you think about retail, you think about the individual and what that consumer experience is, whether it's how they acquire health insurance and their experiences once they acquire it, addressing in many ways many of the things that Ralph just mentioned, really understanding the different segments of the population and how to best position the capabilities they need to be healthy or to get healthy. And so those are the things that we're working on.
Great. So I want to open this up for questions. Please don't be shy. You can come to the mic or you can just yell at the top of your lungs. Howard, while we wait for folks to come up, I think this question of physician leadership, or this issue of physician leadership, is really very interesting. And it's tied to value, I think, and I think you think that. But I also think this embedded in physician leadership is this question of culture. And how do you develop and sustain and build a physician culture of engagement and leadership? How do you approach that question of developing a culture at Peace Health that really supports all of this stuff we're talking about, supports collaboration, supports team models of care, all that stuff? What do you think?
It's a great question. I think lots of large medical groups have suffered over the years by treating their doctors like employees and promote a sense of that mindset that, you know, I punch a clock, I come in, I work a number of hours. By taking away control of the immediate environment of the practice, professional folks like doctors really lose interest in managing what they really should be managing best. And there's a fellow named Daniel Pink, some of you may have heard him speak, who has this great approach to, there's three things that are consistent with professional satisfaction. They're autonomy, mastery, and purpose. And in the medical profession, we're pretty good at purpose because we take care of people who are sick. That's a great thing. Most doctors want to do a good job, and most do. But if we take away the autonomy, most physicians very quickly will lose interest in being entrepreneurial and doing what's right for the patient in their context. So one of the things we've done is we're trying to, within some envelope of reality, of productivity and quality and the things that you want to have in a high-performing medical group, allowing the physicians to control the environment of their practice as much as possible so they're comfortable with it and they set it up the way that they enjoy practicing and feel is best for their patients. Yeah. And changing that culture is what we're in the middle of doing right now. It's not easy because it's gone through years of being the other way. I think it's important. I want to mention, can I just go back
Please.
to something else about patient choice, and this is going to sound perhaps controversial in the state of Oregon. But I believe that we have swung the wrong way in completely having open access to specialty care and EDs and wherever a person decides to go. We can't afford that kind of freedom of choice anymore. And I have to say that, unfortunately, the bad name that HMOs and gatekeepers got 15, 20 years ago has caused us to be very constricted in our willingness to insist on people choosing a PCP and to have that decision be made in a coordinated fashion of going to a specialist, for instance. We know in communities that have strong primary care, the health of the population is better. And we know that probably 2/3 of the time, when a person makes a decision to go directly over their PCP to a specialist, it's the wrong decision. The person they're seeing is not capable of handling the problem, the appropriate tests have not been done ahead of time. It becomes a more costly event. So I think we need to maybe rethink in this culture the idea that it is a good idea to not just promote, but in some ways, I hate to use the word require, mandate, that in order to keep costs under control, people have a primary care advisor or provider to help them navigate the system. And I'm sure there's controversy about that, but I just want to put that out there.
So just to weigh in on that, I had the privilege of going overseas a couple of weeks ago with a group of 30 healthcare executives to study the Dutch healthcare system. And like the United States today, everyone in the Netherlands is required to have health insurance. But in addition to that, everyone is required to choose a primary care physician. And that primary care physician is not a gatekeeper, they're an advocate. And the specialists are all linked to the hospitals. And they have a highly competitive and viable health insurance market who helps manage that component of the healthcare sector. It's a elegantly simple system, and it produces far better results than our system does. But I do think, to the point you made, one of the key elements of that system is the intimacy of the patient with a primary care physician who acts as a caregiver as well as a navigator for them.
So Ralph, you know, when I have heard people say, I heard it at our dinner last night, you know, how do you promote health system integration when that runs headlong into antitrust law, FTC regulation, consumer choice issues, and when we know after multiple studies that price is determined 75% of which by market leverage, not by cost, right? How do you view these kinds of questions of integration of care delivery, the kinds of things that often very clearly produce better collaboration when you're the CEO of a health plan, and as a new one, very limited ability to bring downward pressure on highly concentrated provider groups, be they a hospital or any other provider group. What do you think about some of those questions?
The whole antitrust issue is huge, and it's daunting, and we have areas in Oregon that in essence are already looking very much like monopolies. Communities, counties where there's really only one hospital system, and that hospital system already employs the majority of the physicians in that area. You know, and if they've got economic problems, they have no one to blame but themselves, because there's no one else who can actually manage the cost in that area but them. And in some of these areas, the cost of care in Oregon is the highest. If you look at Portland, for example, we have 5 major hospital systems. If you include Southwest Washington in there, you've got 6. And we actually have pretty competitive pricing across these systems. There's some competition going on there. But if you move further south, particularly if you go down into the Lynn-Benton County area, you have one hospital system. It owns all the hospitals. It's very dominant down there. And it just also so happens that that is the highest per capita cost area, age-adjusted, risk-adjusted in the state of Oregon. Now, maybe that's an accident. But for any particular, here's the problem, and Richard's got the same problem, of course, because regions may have, 25, 30% of the market, but still as an individual health plan, there is no individual carrier in the state that has enough leverage to do much about that. And I do think that as a public policy matter, this is something that people need to pay attention to. And what gets even more complicated is this. If we start thinking about CCOs in the same context, some CCOs have filed for commercial insurance licenses. Now, CCOs were created to be Medicaid delivery systems and to deal with population-based health for those Medicaid populations in their regions. And that's a great idea. I mean, the whole idea of the population-based care, of integrating care with in essence, a capitation for managing that population, puts all of the incentives in the right place in terms of the accountability for cost and quality in the delivery system. But you have to watch out for the cost shift and what might happen if those organizations then file for and receive a certificate of authority to do commercial business and also have a Medicare license. Now you've got Medicaid, commercial, and Medicare under a single entity that is provider-owned. Provider-owned. By law, that's what CCOs are. So, whose interests get the attention here? What happens to cost? You have all the ability in the world to cost shift to the commercial market if you're not getting what you want out of Medicaid or getting what you want out of Medicare. So I worry about that.
So do you think that you see some of this cost shift in the current commercial rates coming over from Medicaid as a result of downward pressure on CCO payments?
I think it's too early to say, but historically that has actually been the case. I mean, we all know that for uncompensated care and the underpayment from the government programs, the commercial market, probably everybody here that has commercial insurance has seen increases in part, and there are estimates about how big those are, 30% I've heard, maybe more, are in fact representative of that cost shift.
So, Howard, you asked a question a year ago at dinner with Don Berwick. I remember it well. And you said, and you were not you were just throwing this out. You weren't advocating this position. I should make that clear, or you can clarify. But you said to Don Berwick at the time, how do we keep great doctors? How do we keep the kind of technology that patients demand? How do we keep great institutions? How do we meet consumer demand unless we can have the resources to pay for that? How do we collaborate unless we have the organizational structure? I'm now paraphrasing because this is added on. How do we collaborate unless we have the organizational structure in which to collaborate? That runs headlong into this kind of view a little bit as well. What do you make of this kind of conversation in light of the fact that you got to pay docs and you got to have buildings, you got to have technology, and you got to do those things?
And Don's answer, if I remember, was quite simple. He said the escalating cost of health care is simply a failure of management.
Yeah.
And that we don't do a good job of holding down the costs in hospitals or in other medical facilities, and we just keep asking for more. And it's a very interesting response, and I suspect the truth is somewhere in between.
Yeah.
I do believe, on the physician side, that there is a physician compensation bubble that's coming. That we're beginning to see that the CMS or MGMA benchmarks that we use to decide how to pay our doctors are beginning to soften and level and are going to begin dropping. Yet in the marketplace, physicians still have the ability to go to the highest bidder. And so I think there's going to become a day of reckoning where the costs, at least on the doctor side, are going to begin to change. It's always hard to be the first one in the market to say, okay, I'm going to start reducing physician compensation, because you don't do so well if you're the only one doing it. But I think just like reimbursements to hospitals is happening already and will continue, I think physicians will have to reset their expectations for income. And on the technology side, I don't have a good answer for that. I mean, this is America. We want the latest, the best, whether it's proven to be better or not. It's new flavor, so it's worth trying. And new drugs, new technology is always going to push costs up in a way that's inappropriate. And unless we get into some government-appointed panel that says what's an okay procedure, what's not, which I think is part of ACA, hasn't been established yet, unless that functions well, we're going to continue to see that spiral.
Yeah. Richard, what do you make of all this conversation?
It's complicated. So it's projected that 1,000 hospitals are going to fail over the next 5 to 10 years in this country, about 20% of all hospitals in this country. And while I agree around the cost shift comments, I think as we move forward, most of that's going to be historical, because what's happening at the hospital level is the shift of business mix or payer mix going mostly to government payers. So the more government patients that a hospital cares for, the less ability to cost shift to a commercial member. And actually there's an even more dire situation that a hospital faces, which is that it's not just payer mix, it's the type of patient that they're going to be caring for, shifting from a higher margin surgical patient to a lower margin chronically ill medical patient. And so there are a number of forces, and there's others in addition to these two, that are going to create intense pressure at the hospital level. And the ability to survive isn't going to be cost shifting or trying to drive more revenue in by capturing the marketplace, by acquiring physicians. It's going to have to be a transformation of the marketplace through collaborations that really get at the population health and cost and allow for access and distribution of dollars in ways different than they are today. So, I mean, we're at the cusp of a crisis because of all of these pressures. And if the healthcare system aligns around its historical silos, the payers, the physicians, the hospitals, the pharmaceuticals, and others, we're just going to get what we've had, except we're going to be in a much more significant crisis. So, to me, I think you're going to see very unique collaborations over the next 5 years. And you're going to see a right-sizing, candidly, I think, at the hospital level as more empowerment occurs between a physician and a patient, and they have more accountability and responsibility to manage that. They're going to take advantage of the opportunities in front of them, including the specialist referrals that you mentioned before.
So, Howard?
I was going to say that in most of the conversations I'm having with colleagues around the country or at meetings, the mantra is learn how to live on Medicare. Yeah. Most health systems recognize that because of the squeeze you're talking about, the uninsured are going to be able to be folded in through the exchanges, but commercial rates are likely to drift downward, and so it'll end up being the Medicare rate. And most organizations are 10 or 20% above Medicare in their cost structure now. Yeah. So this is a huge change. You're seeing Peace Health announced a downsizing recently. Cleveland Clinic just said they're $330 million off on their budget for this year. So even reputable, high-performing organizations are beginning to do some tough things.
Yeah, Ralph, what do you? I think we all. Let me ask a different question. Do you think that the Affordable Care Act? Do you think exchanges are catalyzing this pressure? Are they making the pressure worse? Do they create solutions that alleviate the pressure and move us towards change, or are they not relevant?
That's a great question. The impact of the exchanges on all of this, I think, in the short term are about competition on insurance rates and about innovation among the insurance companies, I think, that maybe hasn't had enough incentive in the past because it's been a pretty opaque system. And it's been largely unaffordable, and for those that had any kind of pre-existing conditions, they were out either on OMIP or they went bare in many cases. So we now have a really competitive situation among all the health plans. And if you just look at what happened in this first round in Oregon, I mean, there were in the Tri-County area here, there were maybe 10 health plans that are now on the exchange, a couple pulled out. And among those 10, about 7 of them repriced themselves to come down. And you can say what you want, but I think a lot of that had to do with seeing what others' rates were coming in at and deciding that they just were too high. So I think just this first round, while some of this was kind of engineered, because I think the Division of Insurance had its hands full trying to figure out how to prevent chaos, they, we did manage to see a lot of rates come down, as much as 40% in at least one case. So that pressure's there among the health plans. Secondly, you've seen innovation really take hold, because now health plans have an incentive to really distinguish themselves on features other than the essential 10 benefits that are built in to that. So they're coming up with all kinds of interesting models around primary care-based networks and HMO lookalike networks, limited networks, the things that we're doing. So all that, I think, is very healthy in the market. Now, I think the question then, to Howard's point, is if there is less margin coming in to these health plans through this very competitive market, does that mean there's going to, in some way or other, be more downward pressure on reimbursement rates with delivery systems? It probably does to some degree. But again, the fact that there are 10 health plans in this market and 14 or 15 statewide means that no individual plan really has a strong arm-twisting leverage on a delivery system to push that hard. So I think it remains to be seen. I think getting back to Howard's earlier point, I think that it really does have to get back to everybody understanding that in this, quote, healthcare system we have today, if it's a system, there are three really important components to it. The first, and each of those three components, I think, needs to very clearly understand what their accountabilities are to the public and to the population they serve. It's interesting because I think you got all three sort of represented here by design or accident, DJ. So you've got the delivery system, which I'll just say that's Howard right now. And it's a really good delivery system. They're doing great stuff. And they're fully focused and willing to take accountability for what they do. Cost and quality, patient experience, they're there. And they're looking to figure out how to do that really well. And that's great. They're going to knock the waste out of the system, figure out how to integrate and lower cost. And by the way, they'll be accountable through the measurements that are built into this accountable care organization structure or CCO structure. Great. That's what they're accountable for, delivering high quality care with a good patient experience at an affordable cost. Health plans, and I'll take Richard as the example of a big health plan here. Health plans are accountable for helping to organize their disparate delivery systems around the state and build the necessary infrastructure in terms of informatics and reporting and measurement and a compensation system that's not fee-for-service but is an alternative system to allow them to do that really well and measure it and report on it. And then you've got the consumer. And this is the part of the conversation I think has gotten very little attention. It got no attention in the creation of ACOs because the federal government didn't want to mess with the Medicare program and the incentives that could or could not be created within that program for the consumer to actually take some accountability here. We all hear and talk about that. What is my role as a patient? What's my role as a consumer in this? Well, stay healthy, stop doing bad stuff that's making you sick. You got to get upstream of disease and start thinking about health and wellness. That's my job. Now, Richard here can help me out a lot with that by building some of the programs they've built, and that's good, but basically it's going to come down to me. But who's telling me, who's really saying that in a way, who's really getting down there into the weeds of my community and working on the social determinants of health as well as the individual accountability and activation? That's kind of new ground, and I think we've got to get very explicit about that and a little bit more dramatic in terms of our benefit designs to enable the consumer to see, understand, and become activated around their own health and, of course, around how they spend their precious family budgets.
No questions. No one's coming forward with hands raised. I know there are a few of you ready to. You're just not sure if you want to get out of your chairs. We only have a few minutes left. And with those few minutes, Howard, I'll start with you. You've gone to medical school, you're on the administrative side now at healthcare. You've probably done some other things in your career outside of healthcare. And you're at this place now where your experience informs your innovation in this very dynamic period of time. And people that I respect who have been in this game a little bit, for a while, will say, DJ, my biggest regret is that I didn't dream big enough and that I achieved all my goals. So what would you say to people in this audience? What advice from your experience, and I'll ask all three of you as our closing question here, what advice would you give today's attendees based on your experience to do with this amazingly dynamic opportunity, this maybe once in a generation opportunity that we have in this time period right now?
Even though I practiced general internal medicine for 35 years and believe very strongly in the doctor-patient relationship and importance of touching patients and seeing them when they're ill, I think the visit to the doctor is terribly overemphasized in this society. And I think the biggest game changer we could do would be to learn how to take care of people outside of the context of the health system. Is to have people visit people in their homes, have monitoring devices that they can feed in electronically to the doctor's office, to have somebody on the staff look at it. There's no reason why we have to see somebody with diabetes and hypertension 3 or 4 times a year. If they're well controlled, they could be monitored by a handheld device now, and we could communicate with them through a portal, through our electronic health record. I think we can do a much better job taking care of a larger number of patients if we get people used to the idea that the actual meeting with a professional provider should be circumscribed around something that's really important, like a poorly yet to be defined illness or a chronic condition that's not responding to routine care. I think with the shortage of primary care doctors and the swelling of both the elder generation and the people coming into the roles through ACA, we're going to have a really great, a difficult time managing care unless we change the paradigm of what care means.
Yeah. Richard, your advice in about a minute based on the experience of your career?
It's tough to ask me to answer in just a minute because I'll answer by telling a quick story, and this should help inform. So my good friend Jeff Brenner, who kind of coined the concept hotspotters in New Jersey, formed this concept of ambulatory intensive care unit, challenged me when I was back in New Jersey that to take the most complicated patient we had, who we thought we were managing well in our collaboration with the delivery system, and he could actually find opportunities. So we risk adjusted and rank ordered our highest risk patients and found a patient on renal dialysis who had been admitted to the hospital 69 times in the prior year. So we looked at was he in case management? Yes. Did he get all the things that needed to occur? Health risk assessment, a visit by the nurse, a review of medications, going to the doctor, et cetera. All of that was done. And so Jeff and one of his staff went out to the dialysis center, and there he was at a scheduled appointment, and he had been coming on a regular basis to his dialysis appointments. And they had a very nice conversation with him. He had been taking his meds, doing all the things that he was instructed to do. And then they met with the staff, and they say, "This is the nicest guy. But you know what? Halfway through his dialysis session, he says, I can't stand sitting here anymore," and he has to be disconnected and leaves, and then obviously has complications. So they went back and talked to him for a moment, and they realized that, as in the conversation, that he liked to draw and paint. So they came back the next dialysis session and brought materials for him to draw and paint. And now if you go to Jeff Brenner's lecture, he'll show a slide with the painting of one of our members after a couple of month period where he drew a beautiful picture, stayed in every dialysis session, and never got admitted in that time frame. So my advice is think differently. I mean, we thought we were doing everything right. The physician who was caring for this patient thought that we were doing everything right, didn't have this information, but there was a psychosocial issue that we would have never picked up, that got picked up through this mechanism, and so you just got to think differently.
Yeah. Ralph, we're out of time, but what advice would you give our attendees based on your experience in this dynamic period of time?
Don't lose your passion, and don't stop caring about the person sitting next to you, your neighbor, the people around you, your coworkers. You wouldn't be here today if you weren't passionate about health and healthcare and making things better for people. And we're in kind of a turbulent time right now, no doubt about it, but it's an incredibly exciting time. I mean, when have you ever seen something like this happen before? And yes, it's easy to kind of get lost and become a cynical naysayer because of all the kind of doom and gloom side of it, but you got to think about the positive side too. There's, for every bad part, there's a lot more that's going on here that's really terrific too. Just the positive elements that have come with the Affordable Care Act. Look, the insurance industry couldn't have done this on its own. It tried and wanted to in many cases, but it couldn't help itself. Now we've got some real insurance reform. I think that's taking us a long way down the road. The elements in there that actually address some of the innovative things that need to happen, address quality, address reimbursement change, and address patient experience, they're all in there. It's going to take some time to adjust and to make these things actually happen. But we've got a great place to start from. So don't lose your passion, don't lose your hope, stay on this thing, stay engaged, make it happen, and we'll get there.
Let's give them a round of applause.